We do have two members of the public in with us today, which is great. It's the first time we've been able to allow members of the public in, so that is very good indeed. So I'm going to start with welcome and apologies. We've got apologies from Tom Crick, independent member, and Deb Lewis, Chief Operating Officer, will be joining late at 11:30. But otherwise, I think we are all perfectly correct. Do we have any declarations of interest for today's agenda? No, excellent. So we start with the patient story, which is how we always start our board meetings. I'm delighted to say that we have somebody that's actually going to come in and do it. So it's not a video, it's an in-person patient story.
Yes, yeah. Thanks, Chair.
Thank you, Gareth.
And can I introduce the board to Jean Saunders? And we have the privilege of hearing Jean's story today, which focuses on the care provided to her mum Nancy at the end of her life, as well as the real challenges and difficulties experienced in medicines management at this time. Notwithstanding the need to hear the story, the aim is to develop a system and process that improves this process for families. And the story also highlights progress being made so far to rectify this problem and still work to do.
Thank you very much. Over to you.
Thank you. I'm very glad to be here actually. So it means a lot to me to be able to relay the story personally. And I apologize in advance for getting upset because it is what it is. But thanks for the opportunity to let me come in.
Thank you very much, Jean. We've got quite a long, thin room. So if you can make sure that and that same goes for all board members as well, actually. We need to make sure we speak up so that everybody hears.
I'm quite deaf, so yes, please speak up.
Everybody needs to speak up to Jean as well. So, Jean, tell us about your experience.
I think my mum had been in hospital for some time and was discharged home for symptom management. And she's been experiencing long episodes of vomiting and which we never really got to the bottom of until toward the end. But she was discharged home with symptoms management, and I must say, you know, the care that we had throughout that time was amazing. We had the support of district nurses and spice, and I was fortunate to have worked in converting surgery as a health visitor and had really good working relationships with them anyway. I don't know whether it's an advantage or a disadvantage being a nurse. I think as a nurse, it was, I felt that I was a nurse and not a daughter. And that's one thing I struggled with because previously my dad had died a number of years ago in the same type of situation. I didn't feel I was allowed to be a daughter. I needed to be that nurse to keep on top of things because I understood the process, I suppose, isn't it? And wanted to make sure that what my mum needed happened. But the problem being was come the Christmas period, although district nursing had planned, we had enough medication, obviously we couldn't preempt all my mum's needs. And the difficulty really is around the syringe driver chart has to be handwritten, it has to go to the GP has to write that chart, then it has to have a script, and then the family member has to take the prescription up to the chemist and get the chemist. And that's when it really all falls down because over the Christmas period, my mum's condition was changing quite frequently and her medication needs were changing a lot. So the timing was quite horrific really because the GP lieutenant was actually ringing me as well to say, how's your mum? Does she need anything? We wouldn't have to wait until the district nurse, or I wouldn't necessarily have to ring the district nurse. So again, you know, I'd have to take the chart down, fill out the chart, pick up the script, go to the chemist. If the chemist didn't have the medications you needed, go to another chemist, and it went round and round in circles. And Christmas Eve particularly, I'd been waiting for some metoclopramide for a few days from one of the pharmacies. And in the end, they said, look, we still haven't got a supply. We want to make sure you've got it for over Christmas. They contacted another pharmacy. So I went from there to Boots, and then from Boots, then contacted Out of Hours, and Out of Hours eventually did the script, back down to the pharmacy, and that would be prescribed incorrectly, so back up to Out of Hours. It was 6 hours I was away from my mum on Christmas Eve alone. And it was time that I should have been with her really at the end of the day. So I think what I want to get across really is that it's nobody's fault. It's the process that's wrong, you know, the timing and the time that families are being asked to be away from their relatives, you know, that's the bit that's all wrong really, isn't it? You know, there are things that I'd like to think that can be done, and hopefully if the board supports some of the proposals as well, that would, you know, shorten that time that the family's away. I think we really need to think about what everybody's role is, what the family's role in the care for their relatives is, what palliative care's role is, etc., etc. Because one of the things was the day my mum sadly passed away, she deteriorated overnight. We called district nurses out, and she was really, really bubbly, and the medication that we had wasn't working. And we called the district nurse back out. She had to go through a really ridiculous process then to try and get advice and further medication, which I ended up having to go back up to Out of Hours for, because palliative care couldn't prescribe. So there's all these things that it was like a sieve, everything was just dropping through, you know, and I just felt that I was carrying the can for lots of things, really, I suppose, and through no fault of anybody, but it was just the way we had to manage it, really. And sadly, I wasn't with my mum when she passed away, and that's what I've struggled with for the last year, because I was out getting the medication and queuing in the chemist to get back, and by the time I got back, she'd gone. So it's, and I really struggled. I really struggled that big time. For 13 years, I'd been there with my mum every day on the phone since my dad had died. I'd been that constant. I battled on the walls in Morrison, and believe you me, I did battle to advocate for my mum, because that's what, you know, daughters do. I'm a nurse, so I advocate even more. And when I really needed to be there. So I hope that puts a little bit of meat on the bones too.
It does indeed. It does indeed. Thank you very much for sharing. And there's a lot to think about. I think we have made some improvements. I think we've also Gareth, did you want to come in, or Paula? Is it you're the?
Yeah,
Yes.
so district nursing is part of my remit and portfolio, but you know, I'm happy to explain the processes, because unfortunately it's not unique to Jean's mum, you know, and Jean's situation. It's a really clunky system.
Yes.
With the best will in the world, if district nurses can go and try and facilitate some of this with GPs and with pharmacists, they will, but you know, the demand is so great now on the service that there's not that wriggle room to be able to do that. I think, you know, there's a couple of things that we need to progress in terms of that electronic prescribing to be out into community, so we can have that communication with GPs. We've got lots of opportunities now where Tywyn, a specialist palliative care, has come to sit in primary and community services, so we can look at opening those pathways there and how we can develop maybe we're talking CT stock and control. Is that something that we could look at holding in Tywyn for community, so we don't have to be expecting nurses or relatives to be running round to different chemists. They're not open 24/7. So it's limitations, you know, if the script has multiple items on it, then if they can't dispense them all, you have to go and get another script for that particular one, or do we need individual scripts for individual items? So there's a lot of anomalies that we need to tie up, you know, and get
Yeah.
smarter and swifter in our processes in order to make that that care better for the family and the patient. The whole point of the patient coming home is to spend quality time in the last days of life with their families.
Yes.
Not the family being
No.
distracted, running around.
No, absolutely, absolutely.
So it's really powerful, isn't it? And I think that phrase there about being the doctor, not the nurse, not the carer, I think is really important because, you know, we all in professional roles undertake a role, and you do jump in and think, I need to sort, but the process was so clunky and so not person-centered that, you know, to be in a position whereby you're absent at such an important time, you know, it stays with you, doesn't it? So no, I think that's really powerful then.
It is a very, very powerful story. Thank you for sharing it, Jean, and I'm so sorry about your experience, but we must make sure that we use that eloquently provided experience to improve the process. Because if you die in hospital, you don't go running around pharmacies, do you? So we need to make sure the same process goes at home.
And we're quite well advanced in e-prescribing,
Yeah.
and we have, you know, lots of good systems. And I think the step into community, and as Paula mentions, you know, having consistency there, it makes it so much easier.
I think the electronic prescribing is key, isn't it? You know, particularly when it comes to the syringe driver chart. You know, that is so archaic.
Yeah.
Isn't it? You know,
Yeah.
and we constantly asking people to move on digitally, you know, but there's you know, I'm not naive enough to know if there's a cost implication that, you know, but there has to be a balance as well, isn't there? You know, and I think we really need to look at what you can do in the first instance, what is achievable initially, isn't it? You know, and what are the long-term aims, isn't it? You know, and the digitalization to me as a nurse is key, really, isn't it? You know, because you cut down that. I don't think for 1 minute families have got an issue with running around and getting medication, because that's what they'll do. That's what they want to do to make sure their relatives are well. But if you can cut down that time, isn't it? You know, so if something's been electronically arranged and you know that you're going to pick something up, what a difference that would have made, isn't it? You know, and it's just so difficult, isn't it? You know, trying to manage a huge organisation as you are, but thinking about that patient at the end of it as well, and that's really key. You know, and Paul's right. My mother's not an isolated incident by any stretch of the imagination. This happened to another relative, a similar situation up in Liverpool only recently. So it's not, you know, in Swansea or Wales, whatever, it is a national thing. And I know Alison's been doing lots of work with pharmacy. The other thing I would like to mention, and I was just saying to Paula, the other thing around out of hours, particularly over bank holidays, is that there are so few pharmacies available. And the only two I could go to were Boots or Sainsbury's is gone now anyway. And the queues there were phenomenal. And the day, as my mum passed, I'd gone to Sainsbury's instead of queuing in Boots. And she said, oh, it'll be an hour. And I just looked and I said, my mum's dying. And in fairness, they prescribed it, you know, when I needed straight away. But unfortunately, she'd gone by the time I got home. And that's another thing I think that we need to take on board, that, you know, the access to pharmacies over those periods are really key. So that time aspect, it could hopefully be reduced. And in winter anyway, last winter, as you know, it was a nightmare. There was a huge virus going around, which I had myself. So, you know, the pressure on the pharmacies was phenomenal. And that's something only on reflection that I've been thinking about, and wasn't something I thought about it initially, but I think again, that's really key.
Yeah.
And I know there is national work going around, with the pharmacists
Yeah.
as well, so,
Yeah, there is no.
but yeah.
And it. I'd like to bring in Matt, who's our Director of Digital.
Hi, Jean, thanks for your story.
I'm
there.
sorry.
Oh, I've got to speak.
If not,
Yeah,
I'm definitely looking forward.
Hi, Jean, thanks for your story. Absolutely concur with everything you said. You know, the data that we need for medication and prescribing is probably the biggest challenge in space across Wales to try and join it all up. Historically, it's all been separate, as you'll be aware. The good news is, as you're aware, there's a national programme that's having a lot of funding put into it to sort this out. The minister, the health minister, it's her highest level digital project priority. And she is driving forward and challenging all of the people who are involved in making it happen on a weekly basis. As Gareth just alluded to, we've made good strides in the health board with electronic prescribing on our wards. So we're the only organisation in Wales at the moment that's got that. But we've only achieved secondary care at the moment. We're working with the national programme now to carry out the next steps, which is the full shared medicine record, so that wherever the patient is or family members, that there's one version of the truth as a record that can be made available at the point of care wherever it's needed. And all of this bureaucracy and all of these extra steps in the processes will be far reduced. It's going to take a couple of years to implement, but the timescales that they're working to, they are meeting so far. And currently, the prescribing method in GP practices is the current focus for one of the projects, and that's happening right now. The other element that's happening and will hopefully go live next year is patients having access to their medication record. So the NHS app, the Wales NHS app will be launched, and the GP surgeries that are ready to provide that information will be providing it via the app as well. So it's going to be incremental, but it is the highest level priority programme. That's all, hopefully you can take some satisfaction from that. But yeah, it is a real challenge.
That's reassuring. I had a conversation with Hamish on Twitter, and I thought you can't do nothing, I'm tired. Hamish had put something on Twitter about the prescribing, and one of the things for me was, yes, it's been rolled out into secondary care, and I did ask, I said, well, would it be available in the community? And yet, it's particularly around end of life.
Yeah.
I think what I was trying to say to him was it's not necessarily about palliative care, it's about GP practices and district nurses.
Yeah.
Because it's they that are delivering the care to the individuals at home. It's not necessarily palliative care. Yes, they're there as an advisory level, but they're not visiting, on that regular basis, a couple of times a day, or on the end of the phone like the GP is. So I was really mindful, and I was trying to get across to, well, please, can you make sure the nursing and GPs are involved in those conversations, particularly district nursing, because I don't know where I would have been without them. It's they were really, really key. And can I also say, Karen Bronner's not here today, but I have to say, Karen Bronner pushed all the way through from the time my mum was in until the time came home. She supported me right the way through, and I'd like that to be minuted as well, because I'd like to more times than I can remember, but I'd like people to take on board how much of a role that Karen had in this as well, and she was instrumental in pushing things forward.
Thank you. Thank you very much. Thank you so much for coming. Yeah.
Hi, Jean. I'm Richard in the internship. I'm just going to say I'm really sorry for your loss and for the experience that you had in particular, and I'm conscious as well that somebody with a health background, as frustrating as it was for you, it would have been even more frustrating for somebody who didn't have that background knowledge. where it becomes confusing, distressing, frustrating. And in terms of what Matt said, what's useful for us as a board as well, we talk a lot about digital, but it's actually you're what we're talking about, not necessarily the app, isn't it? So it's you and your mum and your family's experience. That's why we're doing those things, is to try and improve that. So while we're some distance away from some of these things, you can be assured that we are taking them on, and you help us enormously by making that very real for us, to see what the implications of that is and how that will improve things. So thank you very much for coming.
Thank you, Richard. Thank you both very much.
Thank you.
Thank you very much.
Thank you.
Jim. Thank you very much, everybody. Bye-bye.
Thank you. Okay, a very poignant story there. I'll just wait for Gareth to come back and then we'll move to the business of the board. I think we'll carry on. So the next item is item 1.5, which is to receive and approve the minutes of the meeting on the 28th of September. Can I just ask, does anybody have any questions of accuracy, first of all? Content with those as a record? Are there any items in those minutes that haven't been picked up either in the action log or on the agenda for today? No. Okay, so we accept those as the minutes. We now take the action log. First of all, are board members happy with the closed actions? I'm going to take that as a yes. We've got 2 open actions. The frequency of the workforce resilience report, Debbie and I, we did have a chat, and it's coming in January. Is there anything you wanted to add on that, Debbie? No. So today, of course, we have the people strategy, which is a key document. But yeah, that's great. We're going to vary the theme, aren't we? Great. Thanks.
Hoping that the people strategy will drive our schedule of reports.
Yeah. Thank you. And then the second one is a report to be brought out in the new year on work undertaken to create a culture of permanent engagement. And that's going to come in January. Yeah, fantastic. Great. Happy with that? Good. Okay. So we will now move to the chair's report. This month, the first time I've done a written report, that was in response to some recommendations from our structured assessment from Audit Wales. It is the same issues. If there is anything that occurs between the writing of the report and the board meeting, I will raise it. I don't think this month there is in particular, other than to say that it is very hot across the system. And I know that Richard will refer this later. There's a great deal going on, and we're heading into winter. And I would just like to put on record my thanks to the executive team, to staff throughout the organisation, who are working incredibly hard at the moment. Are there any questions on my report? I draw people's attention to the IM visits. I know that they've already started, and that they are creating, they're generating a lot of thought and insight and discussion amongst IMs. Both in committees and on independent basis, and that will come through to the board as well on a regular basis through my report. Good. Okay. Over to you, Richard, for the chief executive
Thank you
report.
very much indeed. Thanks, Chair. So I'll direct board members to the written report, the bulk, but I will highlight some key issues within that. I think, as Emma said, it would be fair to say, just in opening the report was with a statement of how under pressure the system is, and that's certainly been the case in the past week. We'll see a bit in the performance report about some of the pressures around unscheduled care, but it has over the past few days been exceptionally busy, particularly at Morrison Hospital around the front door, whether it's the perennial challenge of accommodating people who need to come into hospital at the same time as creating room for them by discharging. A lot of what we're doing, and much of around unscheduled care that is described in the report, it isn't just about isn't just about how quickly we see people in the accident and emergency department. It's the efficiency of our processes, which include offering alternatives to people coming to hospital, to prevent deterioration in their health that would lead in attendance to hospital. And then when people are in hospital, to make sure that we're maximising all the opportunities possible to get them as well as soon as we can. And once they are well, to make sure that we're getting them back to their place of residence where we possibly can, or alternative accommodation, because we're very clear that those patients waiting at the front door are the people who need a hospital bed, and we're conscious that we do have many people in our hospital beds where hospital is no longer the best place for them. In terms of so unscheduled care is still very busy as we head into winter. We're going to talk a little bit later about the winter plan. We'll talk a bit more about the performance around unscheduled care. Just wanted to pick out some highlights on the planned care side. One notable positive that we have achieved in the last month is that we've now eradicated all waits of over 52 weeks for outpatient appointments. So there are no longer anybody waiting longer than a year for an outpatient appointment. We've also made big inroads into the next big challenge, which is our 104-week waits for treatment. We've reduced that number of people waiting by almost 600 people in the last month. And we're conscious of the need to reduce that, particularly for those patients who are waiting for the longest time. A couple of things that have happened that will help us enormously with that. The first is the opening of the new theatre complex at Neath Port Talbot Hospital, with the 2 theatres there, and anticipating and hoping that we'll be able to open a 3rd theatre early in the new year. And importantly, just in the last week, we've been working very closely with colleagues in Hywel Dda to see how we can flexibly use the available capacity across the region rather than just in our individual health boards. 27th of November, 3 days ago, we did our first operating list in orthopaedics at Prince Philip Hospital on Swansea Bay patients, which means that by doing an increasing number of people and collaborating with Hywel Dda in that way, we'll have more capacity in Morrison to do the most complicated operations where we know that patients need to be in a hospital co-located with intensive care or a high care unit. And then I mentioned as well that I mentioned Neath Port Talbot and the new theatre complex. It was Neath Port Talbot Hospital's 21st birthday this week, which has been celebrated with a buffet lunch for the 100 or so staff who've worked in the hospital from the very start. So that's a landmark occasion for them. In terms of the rest of the performance, I think we'll pick up on most of it within the performance report. Board members will see on page 9 that particularly we're concerned about our cancer performance and concerned to improve that, to get towards that 75% target that we've set ourselves. We're much lower than we would want at the minute, but conscious that Deb and the operational teams are working very hard towards that, and particularly around some of those areas of greatest constraint for slowing that down. There are a number of items in the paper for board members' approval and information. I'll just direct board members to those. 3.7 about the South Wales Sexual Assault Referral Centre Regionalisation Programme, which is proposals that have been developed by the Welsh Health Specialised Services Joint Committee and for individual health boards to endorse. And then an item on 4.2, which is about the vacant practice panel recommendation about the transfer of the Cwmafon and Cymru General Medical Services to independent contractor status procurement. And then following that, 4.3, the merger of Arford Street Primary Care Centre, Rosedale Medical Practice and Waterside Medical Practice. Management board supported the merger request, and the health board requested to formally ratify that decision. And those are in those papers. I think 2 things in particular I would like to highlight, which board members will become conscious of in the last few weeks. One is the focus that we've received on maternity services in Swansea Bay. We've been working very hard to develop proposals around our midwifery staffing, which has been our single biggest challenge in midwifery, after we needed to temporarily close the birthing centre at Neath Port Talbot in July 2021. We have been actively recruiting to those roles, working towards how we then reopen that birthing centre in the new year, and the Health Board's invested an extra £750,000 in the service over 2 years to meet those birth rate plus standards. We've actually positively had a lot of success in the last few weeks. We've recruited 21 new midwives, which is a mix of newly qualified and experienced staff, and the vast majority of those, 19 of those, have now started work, which means that we're going to review the staffing levels at the end of this week, but we're probably moving out to the period where we've struggled to maintain compliance with that birth rate plus staffing level. And it looks like with that recruitment drive that's happened that we're now able to maintain that, to achieve that and maintain that, and we'll be reviewing the risks around that nature. We're very conscious of the media focus of the last few weeks. Board members will be aware that we've had a number of external and internal reviews over the last 3 years, and they're listed on page 13 of that report. From the HIW Healthcare Inspectorate Wales inspection in June 2019 through to the latest HIW inspection, which occurred in July. We're anticipating that latest review and the Health Board's response will be published in mid-December. And pending the receipt of that, we're also looking at the outcomes that were reported through the Embrace, the acronym, Mothers and Babies Reducing Risk Through Audits and Confidential Inquiries. It's a UK audit. And we're very conscious that for the period of 2021, the 2021 figures were published back in May 2023, that these do highlight a higher mortality rate for Swansea Bay for 2021. And we're considering how we review these outcomes in more detail, and whether the staffing constraints that we've experienced has impacted on that. We will be looking at more detail in that in the current weeks, and then we'll provide a more detailed briefing to board in the January board meeting on maternity. And then finally, just to add a few highlights, I just wanted to pick out two things in particular. So the first, I think, is we're conscious of winter. We're conscious of the potential industrial action from the BMA and the junior doctors in January, so we're working hard towards how we mitigate those eventualities in the depths of winter. There are national discussions taking place about plans for derogations, and we've started looking at contingencies internally. And the one event, there are lots of things to celebrate in the report as well. I've mentioned a number of individuals and services who've been successful in winning awards and nominations. I just wanted to mention the Diaspora event, which was held at Singleton to give international staff the opportunity to engage with senior members of the Health Board. And I think everybody attended that. The feedback that we've got is that people have been what's the best way to describe it? Enthusiastic is probably the wrong word. I think people have been really surprised by that event and by how overwhelmingly positive that had been about the work that's been done in the Health Board, about the work that staff are doing themselves to support people that have come to work in Swansea from other places who've trained overseas. It was only half a day, and I think the feedback that we got, that could easily have been a whole day, but incredibly positive feedback from that. And all of those involved who heard what was happening and heard what members of staff were up to support themselves, to support each other, was incredible. And having that culturally diverse workforce is hugely important to us. It's hugely important to us that then we not only have that cultural diversity, but also that we support people in terms of them not coming to want to come to work for us in Swansea, but also wanting to stay. It's about recruitment, it's about retention, it's about that sense of family, it's about that sense of welcome when you come. It's not just you come and do a job, it's much more than that. And that came through absolutely extremely strongly in that Diaspora event. So I'm pretty sure we're going to do that again soon, actually, and it sounds like we'll make it a much bigger event. And then congratulations, as usual, in there to those staff who've won awards, who've been nominated, and I'll let you read through those. And then finally, the final item there really is on finance, but we've got a very detailed financial briefing that comes on later in the agenda. There's one item that isn't in the written report that I think bears mentioning, and that again occurred in the media over the last few days about the Welsh Fertility Institute at Neath Port Talbot Hospital. We were conscious last month that Welsh Health Specialised Services Committee, who commissioned the service from us, had escalated the service to stage 4 of escalation. It's their highest level of escalation. We're working closely with WISC on that. We're concerned about it's a small service. We're concerned about the sustainability of that service, and particularly how we're able to satisfy meeting the requirements of the regulator, the Human Fertilisation and Embryology Authority. And so we're working with WISC closely on that. It's important to say within that, given the appearance in the media in particular, we have had conversations with staff. The conversations that we're having really about how we take forward considerations for supporting that service, but also conscious that there are a range of options that might be available, but we need to work closely with WISC on that, and we'll be having that close discussion with staff on what the potential outcomes of that might be. But that's the process and no decisions.
Thank you. Thank you very much, Richard. Any questions for Richard? Rena?
Yeah, Richard, I'm really pleased to hear that we've been able to recruit so many midwives and obviously people to work within our maternity services. The concern I have really is that how quickly are we going to get all these stuff up and running so that we can actually look at opening our services fully in terms of the birthing centre and the home birth centre. So I was wondering if you had any idea on timescales on that at this point.
I'll let Gareth pick that up.
Actually, it's a really important question. Is that we've had the successes in terms of making sure we're fully established now with our midwives, and the plan is that we have a gateway review in December where we look at the outcome of the OCPs, the general position around risk, the number of staff we have, and then make a decision as to when and how we open the birthing centre. We're looking at Q4 of this year, so between January and March, but we'd be sort of clearer to the date once we do that gateway review. The key thing there is it's got to be safe, and that safety component will be front and centre in terms of any decisions being made there. In terms of staff being up and running, all our staff have an induction programme. All of the staff who are now on our rosters from this week have had the induction programme, so they're all live and they're all doing their job and are settling into the service there. And as Richard mentioned, you know, we're at a point whereby there were 19 new staff. We're now working over and above what we really require on each shift, and we'll maintain that now moving forward. I suppose the other exciting thing to mention on the back of that is the recruitment of our new Associate Director of Midwifery. We'll be interviewing for that post on the 20th of December, and again that'll give us some supportive senior leadership there. But I'd be keen to bring the timeline back to board once that gateway is taking place, so then we can really give some certainty around next steps.
Thank you. Thank you very much, Gareth. Support to the staff, because it's a hard time for the staff.
It's tough, isn't it? You know, and we're in a position whereby we now meet with the staff on a weekly basis. We meet on a Friday morning. Our first open meeting, we had, I think, about 80 staff there. It's reduced a little bit over that time period, but the premise is we'll be there even if one turns up. We'll be there and we'll have a discussion and we'll help and support there. We've also got a really sort of structured process around visibility. It was great taking a walk around with you yourself a couple of weeks ago, and I think you really get a feel for what music is like by going there. Our psychology teams are involved there, the Guardian service are involved there, and just having an open access to any of us in terms of concerns that are being raised, you know, and our staff, you know, are tired, you know, and you mentioned doing the weekends and early on, you know, across all our services, our staff are working exceptionally hard. But for our maternity service, we need to ensure now that we maintain that degree of support there. Because again, it's such an important service to us.
Yeah.
The other thing just to mention is that we obviously got our Maternity Voices committee, and our mums and service users are giving us some excellent feedback about how we can improve our services, and really positive feedback on the whole about the experience that they've had. So a lot going on.
Great. No, thank you.
Just in terms of what Gareth was saying about staffing arena as well, a couple of important things. Whenever we set our staffing numbers, we always allow a bit of an overhead for leave and for maternity leave. We've decided to go over above that, so we're over recruited currently. So the overall numbers that we'll have will be more than we actually need, conscious of the need to maintain that safe service. Your question as well is key to what I think sort of partly referred to in the diaspora conversation, which is recruitment never stops because we're always keeping pace with people who leave or retire. So that's a constant cycle. And part of what we're doing then is being conscious of not only the recruitment element, but to retain staff as well. So that is an important arm to this as well. It's not just a single one-off event of recruitment. It is a constant process to make sure we can do that. And that's what we'll be looking at leading up to that gateway review for Q4.
Thank you. Any other questions for Richard? Steve?
Yeah, a couple of comments, Chair. The vacant practice panel, which I chaired it, so I know what went on there. The Clice were there and the LMC were there, and I think the population up there have not been well treated, particularly in terms of not well served in terms of GP practices. And I think that the solution that we found, which is to keep the two practices combined, but then to offer them to the market. And we've had informal interest, I believe, from within the cluster and also outside the cluster. So hopefully soon there'll be a proper, strong GP practice up there, which can look after the communities previously looked after by two very small practices. And I was also going to talk about mention the diaspora event. I was there and it was a great event. You're right, we should do it again. One of the statistics that came out of that, and Debbie and Gareth and I spoke about it at the time, was that nationally 64% of overseas recruits don't feel that their professional experience and qualifications have been properly utilised. Now, we don't know in Swansea Bay what our statistic is, but we were quite keen that we should be not part of that statistic, because why waste their talent on doing things that they are too qualified to do? But we should certainly do it again.
Thank you. Jean?
Just on that last point, Chair, the people strategy, I think, would take into account the transition opportunity of managing our overseas staff now. Because whilst they're trained, they're very well trained staff too. And we have to manage that transition into the workplace so that they don't lose momentum in the opportunities that they've been given at front of their appointments.
Yes.
And we don't lose their experience either by putting them back into a place where they don't belong and have further abilities than maybe we are looking at.
Absolutely. I can see Debbie nodding, and I think we'll pick this up again when we come to the strategy. It's a really important point we discussed at design analysis today as well. Any other questions? Yes, Darren.
It's just a point on the approval of the sexual assault referral centre funding. Clearly, we've got a very challenging financial position at the moment, but we'd always anticipated and had planned for this. So this isn't future decision making, it's just to assure the board that post modest allocation, we're obviously scrutinising every funding decision, and that money is available in the overall plan, should the board be minded to approve it.
Thank you very much indeed. If there aren't any other questions, then I'm going to ask the board to ratify and support those three things. So first of all, the transfer to the independent contractor status for Cwmar and Carmarthen, which I think is a very positive step. Secondly, the merger of Alfred Street and Rosedale GP surgeries, again, been through a proper process. And thirdly, the sexual assault referral centre, which again has a long gestation, doesn't it? Which again is a really important development. I'm seeing nods. Great, fantastic. Thank you very much indeed. Thank you, Richard. So we now move to the board assurance framework. Hazel.
Yeah, thank you, Mr. Chair. So this is before the high levels document that board members use as part of our assurance processes in terms of understanding the risks to the health board achieving its objectives. Independent members use it as part of the governance setting where appropriate to seek further assurance, and we also use it in terms of the planning of the annual internal audit programme. It is an ever evolving document. We've had reasonable assurance from internal audit from the audit. Plus we've had some positive feedback from Audit Wales and the structured assessment report that we come to the January board in terms of how it's evolving. I think that's all I wanted to say, Chair, but happy to take questions.
Thank you. Thank you very much, Hazel. I mean, we discussed this yesterday, and I think the general feedback from IMs is that this and the risk register are a good start to the board. We're starting to get a really good sense of the assurance and the risks of the organisation. So that's really positive. So Pat.
Yeah, as you said, Emma, this is an ever improving report. It's improved, greatly since it was first written. A couple of points. I think sadly that the urgent emergency care and cancer care described as limited assurance is probably a better reflection of where they are given the balance of performance issues and risk at this time. The children, young people and maternity, that's a big bucket of activity. And we've heard a lot about maternity and where maternity and neonatal are going. If you then compare that to the young people services, so you're looking at the issues with CAMS, we've got a 20 risk there. You're looking at possibly the NDD performance, speech and language therapy for young people. There's some real challenges there. And I feel like those two areas of the service are in very different places. So I was just wondering whether it'd be better to split into two to better reflect where they are. And finally on the shortage of discretionary capital, we have captured, there is a risk 93, which is 20. I don't know whether we fully captured either in the risk register or in the BAF the impact that lack of capital has on the estate and how fit for purpose our estate is and the backlog maintenance, etc., and the risks involved in that. So I don't know whether we need to think about how we reflect that, maybe in it's section 7, isn't it, about the estate and health and safety, etc., whether we need to better reflect that.
The sense that it's more of a financial risk than
it's in as a financial risk.
Than a quality risk.
Yeah, but there are massive risks to the quality of the estate.
Yeah.
Hazel, those two fair points, and we have had some discussions in terms of young people maternity and do we split that. So those discussions are being held and we're working through that. So I would imagine that in the next iteration to the board, I think is feedback in March, you will see that split then, and hopefully see it earlier from agenda planning as well. And I think in terms of the capital, then we can certainly work on that and provide an update there as well.
Yeah.
Thank you.
Louise.
Thanks. On that same point, I think it's not just the capital. I think one of my concerns is, as a member of the Health and Safety Committee that has taken in the health and safety agenda, is that there isn't anything to reflect the fact that there is risk to staff as well as visitors and patients as a result of deteriorating estate. And I think I'd like to see that more openly reflected, so that we are looking at it, and where there is some capital and spare cash, we can, it's like it's the mending pothole to stop people falling down it. But I'd like to see.
Thank you. Yeah, no, fair points. Thank you very much. Darren.
I would address the problems in the room, because it's a big presentation that we have to acknowledge. I think that's a very sensible thing to raise. We are making progress in terms of strengthening the health and safety team, and I've brought together the capital, estates and health and safety team under one leadership now to try to exploit some of the synergies between working, so it's probably working smarter and harder, but not perhaps with a substantially increased resource. So we're certainly welcome conversations outside the room to be able to capture that in the right way to give those committee leadership.
Yeah. I think the point was slightly different. It wasn't a reflection, though I'm pleased to hear what you're saying about the restructure of health and safety. I think it was more that we think about it as a financial impact, but actually we're not fully reflecting it's outside our control. It is a genuine risk to our health, to the health and safety of our ability to provide health and safety. Yeah. Other thoughts, questions? Just one from me, around, you know how I like third level assurance. Particularly around quality and safety, there's a lot about the audit and assurance reports, but I think there are other third level assurances that can go in there. That we get. So again, it's just about developing the back further. I think that would be a positive development. Otherwise, thank you very much indeed. So should we move on to the risk register then?
So the health food risk register is ended to the report. The process is we review and update every month, and the executive directors sign off the updates as well. We've got 2 new risks detailed in the report. Sorry, 3 new risks. 2 risks where the scores have increased and 2 risks where the scores have decreased. I think in terms of the scores where risks have decreased, we're looking to assign those back to the service group now for oversight. There's also a risk scrutiny panel process in place that we regularly review risks escalated to us from the service group as well, and make a decision in terms of whether to include them on the health food risk register. We do have a number of risks that are at our risk appetite or above, detailed in table 7, so just draw board's attention to those risks there. And we've made really good progress in terms of the risk management workshops we've provided to all service groups, now re-offering those as well, and strengthening the training that we provide to service groups as well. So that's all I wanted to summarise, and happy to take questions.
Thank you. Thank you very much, Hazel. Rena.
Yeah, Hazel, I'm finding this very useful, I will say, because in terms of setting the agenda for the committee that I chair, I do feel it is very important that we look up this and recognise whether we are looking at the right things from the committee. So it is really helpful. The only, I mean, I'm really impressed that we've managed to embed this within the organisation and we're all using it. But I do feel the embedding of risk thinking probably could still go a little bit further in terms of the way in which committee reports are prepared. And I've noticed recently that a lot of them have got a section on risk, which is really helpful because it focuses your mind as an independent member as to where are the risks in this, and what are they, and what are we doing to mitigate them. But I think, I'm not sure that they're all the time. So I think we could just do a little bit more to strengthen that risk thinking in terms of the officers who are preparing the reports.
Yeah, I think that's a really good point, and that's part of our board effectiveness action plan that we'll come on to later on in the agenda. We've also having a board development training session in terms of integrated risk management even more than what we do. So I think that will continue to evolve as well.
Great. Thank you. Other thoughts? I mean, overall, I think this illustrates what I said at the start, which is that we are carrying a lot of risk, some high risks. But it is also very good to see that some risks that were very high and we were very concerned about a few months ago have gone down. I'm thinking about GIRF and the Burns unit. So this is the board is looking at the risks and addressing them. Can I just ask about the Home Office CD licensing that has gone up? I know it's 16, so in the context of our very high risks, what's behind that?
Just wanted to Judith.
Judith, is there anything you can? Sorry to put you on the spot.
Yes, there's. Can you bear with me? I'm just trying to get it up in front of me so I'm
looking at it's risk number 57.
Really,
yeah, make sure we speak up so that we can hear at the end of the room.
So it's really in relation to the Home Office view in terms of where we need license for our controlled drugs. And you know, during the pandemic, we did take advice, and we were working on that advice, and then hearing more recently from the Home Office in terms of their interpretation of the legislation. So we are now working with them really to put those licenses in place. But we've just increased the risk while we do that, but there's a clear plan in place to bring the risk down in gaining those licenses.
Okay, thank you. That's great. It's good. Gives a lot of assurance, actually. Judith?
Apologies, admin control had shut down on me, so I didn't have the paper open, so apologies for that. Yeah, I think Hazel has summarised that quite well. So obviously I'm covering the Controlled Drug Accountable Officer role within the Health Board. Home Office met with us earlier this year and advised that we needed a series of licenses, which we've now applied for. And I've had a series of compliance visits and we are awaiting the outcomes of those. There doesn't seem to be any major problems with that. So I'm confident that we'll be able to reduce that risk shortly once we get all of the information back from the Home Office.
Great, thank you very much indeed. Okay, I'm not seeing any other questions. Thank you very much indeed, Hazel. So we will now move to the key issues reports, first starting with Quality and Safety Committee. Steve.
Yep. So 2 meetings formally to report on, and we had a meeting a couple of days ago also. Themes that are running through the whole thing. We've got the clinically optimized patients issue. We had a deep dive report into that in September. That is still an issue now in November, where it has been for many months. And it was an issue that came through in the Morriston Highlight report in the October meeting. So clinically optimized patient flow. We've now got the continuous flow model, which we had a presentation on 2 days ago. But it's still a big issue for us. We still got more than 200 clinically optimized patients in our wards, and that's too many. And you can keep the flow going through from the front to the middle of the hospital, but if you haven't got a flow out through the back door, then it doesn't work. There was a point raised by some independent members, and I should raise it and ask for an executive response, that maybe the closure of the Singleton wards happened too early, and that there are now empty wards in Singleton and clogged up wards elsewhere in the estate, and maybe that's a potential answer to the problem. But I'll invite a response to that in a second. We've got issues again through the piece of infection prevention and control. We are outliers in Wales, unfortunately, not in a good way, in most of those infectious areas. In particular, Morriston is an issue, and it's not the whole of Morriston, it's bits of Morriston, because there are some wards in Morriston that haven't seen an infection for months or years, but there are others that see them quite regularly. And we know why, because it's an old estate, and because it's full up, and there's no chance to clean the place properly. But it remains a high risk issue. And I mean, the committee, we previously had infection prevention and control reporting to us every month. It then went back to coming through the quality and safety group, but we've asked for it to again come back to the committee as a standalone report each quarter, because it's a risk, and it's an expensive risk to us. There were issues about in primary care, access to dentistry and access to GP services back in September. These are still noisy areas through the piece. I think with dentistry, it's sometimes a communications issue, because we are in Swansea Bay providing more new appointments than anywhere else. We're doing a very good job in that. The communication issue is that people don't understand that they don't have to go to the dentist every 6 months anymore, that some of them only have to go even every 2 years, but certainly every 1 year if you've got a healthy mouth. The old thing about going to the dentist and then checking in for 6 months' time, it no longer applies, and people haven't got that message. We had a number of complaints came through the managed practice that we talked about earlier, also in the prison, and that's an area that we're not dealing with complaints generally, we're not particularly good at. There was a positive report 1 year on from the CCN Children's Community Nursing issue. and there's been very positive progress there. And I guess the final thing, in the October meeting, we had a deep dive into one of the health core priorities, which is end-of-life care. And we're doing some good work there. But one statistic which came out, which was pertinent to the patient story we heard earlier, that in Swansea Bay, 52% of people die in hospital, whereas in Wales generally, it's only 42%. That's quite a big difference. And you know, maybe the issues around end-of-life care in people's homes that we heard one facet of earlier, is one of the reasons why people are coming to hospital to die or are staying in hospital after a deterioration in their health, and don't go home to die. So it's an interesting statistic and not one we should be particularly pleased with.
Thank you. Thank you, Steve. Can we pick up on the challenge you gave the objectives around the single beds?
I'll start, I think.
Yeah.
Right. So I think it's a really fair point, but I would say that what we've done in the last 12, 18 months about the reconfiguration of our services, it's more than really about closing beds, and it wasn't just about moving the acute medical services to Morriston necessarily. It was about the model that sat around that. And then in doing so, what we made sure is we had a front door of Morriston with all of the skills at the front door, rather than trying to split them across two sites, which we had previously, where we were very aware that we had some specialties on the Morriston site and others on Singleton, but not necessarily on both. So everything is co-located in one place. And in that new unit at Morriston, we've obviously got our urgent primary care, our GP sat alongside our same-day emergency care, sat alongside our acute medical patients. And of course, in totality, in terms of the bed numbers, within that, we created an entirely different and new unit with beds in the acute medical unit on the Morriston site. So I think the benefits of that outweigh, the benefits of having that co-located mean that we're able to get people home quicker up in the front door rather than. We do have vacant wards at Singleton, though. That's quite right. That's not to say that. And I think the point I'd make about that, so why don't we use those, is I think that the point made at the beginning about the clinically optimised patients is we want those people in the right place for them, and that a hospital bed isn't the right place. And I think, again, a bed within our hospital estate isn't necessarily the right place, which is why the model of care, and that means that we're working really closely with our local authority colleagues on looking at alternatives, as well as some of the schemes that we've got in place to avoid admission, to provide alternatives to admission, to avoid admission, in other words, discharge people quickly when they come in. But I think it is a fair point in the sense that as we get into the winter, we're fortunate maybe that does mean that we have capacity on our hospital sites to look at whether or not that might be an option for surge for the winter. The challenge, as ever with those, is we might have the space, but we don't have the staff. And I think there would be an additional challenge on the Singleton site, in particular on the model of care that we provide for any ward that would open up on that site, given that we've now got that concentration of the medical expertise, in particular at Morriston rather than in Singleton. I think it is a fair point. It is something that we'll consider, and it is one of those we're fortunate, I think, in having that as an option for us to consider as surge for winter, but that wouldn't necessarily reduce the challenge for us in finding a suitable staffing for people.
Can I just follow up then? Because if effectively what we're doing is providing beds in the community that used to be provided on the acute site, are we confident that that bed capacity in the community is operating as effectively as it should be? And I'm thinking particularly when we've got Morriston in a high state of escalation, is that reflected all the way through the system?
So that's a really good point and an interesting question. So we've currently got 8 virtual wards, which is equivalent to 80 beds, Angela, is that right? 240. Sorry, yes, that's a huge number of virtual beds. Now, the challenge with those virtual beds, it's easy to count a person in a bed. It's less easy to count what a virtual bed is, and it's easy to count length of stay. So I think we've made those developments. Those virtual ward beds will accommodate a number of things. They will accommodate patients that were able to step down from hospital So in other words, we're able to discharge somebody home with the support of the virtual ward, rather than them being in hospital. But we're also provide anticipatory care for patients who may be deteriorating in the community and provide them the virtual bed rather than them coming to hospital. What we don't have to the same extent, and it's because of that issue, it's easy to count a bed, the physical bed, is we probably don't yet, have the we don't yet have the granularity of data and things like length of stay, occupancy, throughput. But we're working with a team on that. Something that particularly we're looking towards going into winter is how we escalate within that sort of time when we say we want to increase discharges before the weekend for our hospital beds. How do we do that for the virtual wards? How does that community aspect respond in the same way and up the level of care that they're providing up their throughput at a time when we need it most? So the short answer is we've got some data, but not all that we need. Probably not enough yet to be able to make that evaluation of what does step up look like, what does escalation mean for those community services. But Angela might want to comment a bit.
Yeah, Angela? Yes, and thank you for that question. I think it's the important bit for me is I think the link between the community and secondary care, that interface needs to be really tight, because we're actually dealing with the same patient. We're just about presenting at the front door or deteriorating in the community. We are just managing the pathway. So it is about that closer linking, that better communication, so that we can capture the patient at the right time. Completely agree with the transparency of the community capacity needs to be there. I think there are more services than the virtual wards. Of course, there are district nursing services. We've got the Home First service. We've got our community enablement teams. All of that capacity is maybe not as visible as it should be, and I think it needs to be, and it needs to be visible for secondary care to utilise it. So it is always that sort of ability to use a service when you know about it and when you are able to see if they've got capacity, you've got those links of communication, that needs to get tighter. So that working together is something we're really keen to improve. And I think the other bit, which we really need to work on over the next few months, is our offer for frail elderly patients. So it is about making sure that we are avoiding any unnecessary admissions we can, capturing those people in their own homes and doing their first assessments in their first homes rather than at the front. So I think there's more to go at around frailty, but we are confident in Swansea Bay. I think that we've got all the components, all the tools, but now the virtual wards and services in the community, it's just about linking them together so they're making that impact at the front door.
Thank you very much, Angela. Richard.
I mean, just to illustrate the point with a practical example, so a personal experience of the virtual wards when my elderly father was in hospital in Morriston and wouldn't have been discharged, I think, without the virtual ward being there to support him. It was time limited. The support was intensive, number of different calls per day. My parents were really impressed with the multidisciplinary communications that was happening. Everybody was having those conversations, so it was very, very joined up. But then it reached an end point when my father actually got better and was recovering significantly. And now I think it's got to a position where he won't be readmitted, which is obviously one of the aims of the scheme. So the virtual wards was massively, massively positive and a huge, huge help.
Thank you. Any other questions for Steve?
I just
Yes, of course, please.
on infection disorders.
Yes, please. Yes.
And Steve, thanks for highlighting that. And I think that a key piece of work here, I think increasing the frequency of reporting safety is a good thing, and I'm glad that's been suggested, so we can give that oversight. But every case of infection now is reviewed. We've set up systems in all the service delivery groups whereby all our tier 1 infections have a review by a senior clinician, a nursing team and the like there. And what that's enabled us to do is to really get underneath whether these infections are avoidable or unavoidable. So the ongoing reporting, we'll report it all as we are now. But that point around avoidability, I think, is key. And it's interesting, Singleton is a wee bit of an outlier for us at the moment. But the frailty of people that we have in our cancer service, the amount of medication, antibiotics that they receive in, almost puts in a point where something like C. diff is going to happen, because they need the antibiotics to enable them to be treated and be supported there. So I think it'll help the conversation in quality and safety moving forward when we get into that avoidability state as well.
Yeah.
And thanks for highlighting Morriston. It's like the two halves, isn't it? The Staph aureus rates in Morriston, they've reduced by 48%. So people having ventlons in and having blood infections, but they see diff levels, you're right, it's probably 5 wards. So we're having a real focus on those wards now to see how we can reduce it. And Pareto's law will tell you deal with the top 5 and your numbers overall from them. So a lot of positive work there. I think we can give assurance, quality, safety about moving forward.
No, that's great. We had a report from Public Health Wales of the Chairs Group as well. I think they're looking to collate some data, also linking to bed occupancy levels and some of the environmental things as well. So it is a picture, but I did say we'd be very welcoming of that, looking at our data compared to others. Good. Can I just ask a question about the dentistry and specifically this centralised waiting list, because this is something that comes up at the national level as well, and I think that they're waiting for us to do, but I'm not sure we see that there's a benefit to having because you're not registered with a dentist in the same way that you're registered with a doctor. Can I just clarify what the position is on that? Is there anyone?
Do you like to know the dentistry?
I think there's been a lot of changes within the contract in dentistry, and there's been a reform, and that has made a significant difference, I think, to access and the way access is now coordinated. So I think and also governed. So I think there's going to be from that the ability to monitor the access within within dental practices better, and I think the reporting process is now much more regulated within the contract. So I think there are opportunities to improve if there are current issues experienced.
Okay, I think it'd be I wouldn't mind just getting an action on the specific issue of the waiting list, because I think what came through in the quality and safety report was slightly at odds with my understanding from a national level, which was they were expecting us to do it, we're expecting them to do it.
I'm supposed to be asking questions, not giving answers, but I know that Brian has looked into this.
Yeah.
And he's not a fan of the waiting list concept.
No.
And whether it be a national waiting list or a Swansea Bay waiting list, he doesn't think it will work. Because people go to another dentist, they can't get it and they stay on a waiting list. Or they go to our urgent dental provision and they stay on somebody's waiting list, because you're not going to ring up all the dentists that you're on the waiting list for and say, I don't need to be on that list anymore. So he doesn't think it will work, but it's worth asking him to come.
And until we've got a national, until we're all linked up, then and we can do it automatically, it's not going to work. Yeah, okay, fine, thank you. Okay, shall we move on to performance and finance? No, am I right about that? I am right. Performance and finance committee, Lena.
Thank you. You've got 2 reports here, first one from September and in October, and obviously we had a meeting 2 days ago as well. So in a way, if I roll all the finance together, obviously we were very concerned that we were in the position we were in October in terms of Morriston particularly being well overspent for where they should be, and particular pressures there coming from variable pay and from other areas. Nathan Talbot was similarly overspent in terms of where they should be, but the main pressure being on prescribing. So we noted that in both September and October. But then we had some good news in the November committee, and that is being referred to in Chief Executive's report earlier, in terms of additional monies was made available to us from the Welsh Government. And so in our November meeting, we were able to establish that what we were trying to achieve now was an 18.8 million shortfall to get to our control total of about 17 million, which I'm sure Darren will take us through shortly. And what I would say, though, in the committee, we were clearly wanted to get more assurance in terms of what is the plan for achieving the 18.8 that we need to find by the end of this financial year. And members sought particular assurance on the impact of that on planned care and where savings were going to be found in terms of the service areas, particularly Morriston, which is clearly under so much pressure at the moment. So I'm sure Darren will go into that part of his financial report. In terms of the other areas that the committee looked at, obviously we looked, as our normal way, into a detailed look at performance. The areas that we were flagging as concerning were the weights on orthopedics, but hopefully that will be improving now we've got the new theatres up and running in East Chandler. The concern about cancer, which has already been referred to, and obviously we still are not where we want to be with cancer, but I was reassured at this week's committee by Raj and the work that he's been doing to try and, in a sense, identify and ensure that we're clear on which areas and what we need to do in each of the different cancer sites. We also had a deep dive report in September on urgent and emergency care. And interesting facts that came out during our visits recently to urgent and emergency care, both in Morriston and Neath Talbot, is that obviously I'm just saying this, if people know it, well, there we are. But we have one of the busiest A&E departments in Wales, and we have the busiest minor injuries unit in the whole of the UK. So, you know, we are doing very well, given that that's where we are. And in a way, we can't affect demand. And what was interesting in the visit to the minor injuries unit, particularly, was the number of people who were coming from outside Swansea Bay to use our unit because it is so efficient and clearly cost effective. But in that sense, it is a resource for probably the whole of Southwest Wales. Anyway, just some interesting facts there. The other deep dive areas we've looked at over the couple of months have been cancer, as I said earlier, that was a particular concern, and we're keeping a close eye on that. And pathology, and that links to cancer in a way, because one of the concerns was that some of the urgent and emergency cancer cases were not getting promptly diagnosed through pathology. And I know they've put in place new measures now to ensure that we can prioritise these cases and to minimise the risk of people having to wait for a diagnosis. I think that's probably it. Oh, the last thing, there was a presentation on necrophema, and that came out of a question that was asked at committee in terms of the ability for people who have had a hip fracture to get early access to theatre, which is obviously one of the key factors in them making a good recovery. And coming out of the discussion on that, what we learned this week was that we are going to be making available some ring-fenced beds specifically for necrophema.
Oh, excellent, that was my question. Good. Any questions for Rena?
Yep, just a comment. An additional thing we looked at as well, Rena, wasn't it, was the kind of scale of the financial challenge for Swansea Bay and for NHS Wales as we move into 24-25. And the committee's in discussions with Darren about kind of what information we need about run rate reductions and savings as we move into next year to give that level of assurance, because it is going to be incredibly challenging.
Yeah, next year. I know we're coming to you next, Darren, so are you coming in on this?
It was just specific in Pat's point because the paper and the agenda deals with now and this year rather than the current picture. So just if I may.
Yes, please.
Obviously there is a significant run rate problem within the organisation of around 60 million at the moment in terms of meeting pressures and demands, not just in the service provision, but prescribing and general inflation. We're doing quite well on a savings delivery this year, but savings delivery on a recurrent basis is challenged as well. And preliminary conversations with colleagues in government are indicating that the settlement for Welsh Government, and therefore by default NHS next year, may be as bad as flat cash, i.e. no additional money. So for us, just on that next year piece, getting into the run rate position in the next 4.5 months, and we started trying to do that already, embracing the ideas and opportunities that are coming out of the National Value and Sustainability Board, I think we really need to get a hold of, so that when we hit the 1st of April, or before that if we can, meeting into that 4 to 5 million a month more than we can afford at the moment. And there'll be other factors as well, perhaps a wage award next year, another consideration. So I've not been able to give the committee forecast number yet, and I'm in possession of all the moving parts, but it's safe to say that the impact of letting this year run into next year unaffected is a substantial opening deficit that we won't be able to tolerate. So that's where the work and the effort needs to be taken.
And the board will want to see, I know we've got plans in place to take the board through that, because I think we're going to need to be very clear about what we're doing in terms of run rate. But then in terms of flat cash versus pay awards, there are going to be some decisions that are going to need to be taken within the health board and across the country, I'm sure. Yeah. Richard.
Excellent. I was just going to say in terms of the hip fractures, that's really interesting, Rena. The outcomes and the key performance metrics for fractured neck and femur for hip fractures are available on a website called the National Hip Fracture Database. And actually, we benchmark really well with the rest of the UK on that, with the notable exception of a couple of things. So, firstly, since COVID in particular, the one metric which has deteriorated across the whole of the UK is admission to a specialist ward, where we can see that the national average within the UK is only 80% of patients get to a specialist ward within the first, I think it's the measures within 4 hours, I think, isn't it? It's 1% in Swansea Bay or 1% at Morriston, which is where, so it's very low, it's too low, but it's a common problem. And the second is prompt surgery. So we don't have enough people who get their operation within 24 hours, and that's another key thing that we need to do, and that's what those dedicated ring fence beds will address. On the others, we are well above the national averages. So in terms of being seen by an orthogeriatrician, obviously many of the people who fall and break their hip are frail and elderly. 97% of people in Swansea Bay get seen by an orthogeriatrician, compared to about 85% in the UK. Our surgery is compliant with NICE best practice in 75% of patients, which compares to a UK national average of just under 70%. And there are a number of things, but you can have a look on the website to see how we compare, and it is really clear where we benchmark well, where we'd actually want to make improvements. So it doesn't necessarily mean that we are above a national average, means that we are where we want to be. But for the vast majority of things, we do really well. But it is noticeable that what we really need to do is to get people to that specialist ward and then get their operation done quickly.
Thank you, Richard. And just to follow on from that, I remember when I first came here, that was not the case at all. And in fact, an orthopaedic surgeon drew my attention to how poorly we compared on that national data. So that is it's good to see that improving. Okay, I think we will now, unless there are any other questions, we will move on to the finance report. So over to you, Darren.
Thank you, Chair. So 4 key things in this month's report. There's the usual routine position in month, but there's also an explanation of the change in forecast and control total, some of the options and choices to meet that, and there's an element of cash management as well, which I just need to touch on. Given the nature of the significant changes we've had, I wasn't going to dwell particularly on the month 7 financial position, because I think the discussion is probably best made on the choices to meet the control. But I will explain what's happened to the financial position just to set that into context for the formalities. So through the good work that Welsh Government have done, we're going to be receiving an extra £60.8 million this year. 43 million pounds of that is recurrent and 17 million pounds of that is non-recurrent. And we fed in 7/12 of that already into the position. So we've gone from having a £60 million overspend down to a £38 million overspend to date. But because of the adjustment of that income and the way it affects our plan, we are still 19 million off that. So that's the position to date. There are 8 or 9 pages of other detail in the report which set that out. If I can take the board then to page 13, where we can see the impact of this year's plan and of the funding coming into the system. What you can see from that waterfall is we had an £86 million projected deficit, with £63 million worth of pressure against that deficit, and we've managed to identify £53 million of mitigation, and that's our original plan. So we're about 10 million off the original plan. When we had the £60 million allocated, we were also given a further stretch target by Welsh Government of 10% of the original deficit, which reduces the plan further by another 8.66 million. In terms of where I'll go next, in terms of the choice, it's really important that the board understands we were 10 million off the original plan, and we've been given a further stretch of 8 million, which is the 18 million gap which was articulated in conversation so far. So that sets where we are. can then draw the board's attention to pages 14 and 15, and that will start to set out some of the options we've got to close that gap further. And the table at table 9 on page 14, firstly breaks down the things we've already got in the plan to address the original gap, which comes to about 54 million. And then table 10, which is a really important table here, shows that as a result of the work we've done with detailed forecasts with the delegated parts of the organisation, and some of the activities we've undertaken recently to review the plan, some opportunistic gains and other choices we could make. We've actually identified 24 million pounds worth of potential deliverable solutions against the 18 million pound gap. Been around the block long enough to know that not all of those ever land. But what would be important to bring to the board's attention now is the nature of the construct of those and the options and choices that brings and the consequences. So on page 14, as I said, you can see the construct of the 24 million, and I draw the board's attention specifically to the recovery activity line in the table, which is assessed as 3.5 million, and the line which is allocate targets to service areas of 9.8 million. Within the 9.8 million, there's just over 6 million pounds, which shares out the burden of the control total we've been given into the delegated budgets of the Health Board. So effectively what that means is, based on the forecast we've already received from every budget holder, we can ask them to do more. And that's particularly pertinent because there are a number of areas in the Health Board where we've actually, our delegated budget holders have done exactly what we've asked them to do, achieve a break-even forecast and meet the savings. We're going to have to ask those individuals to do more. But that's part of sharing that out. One of the tests we've had, and we'll go into the detail now, because I think I may be best going out in questions, Chair, is the confidence within which we can deliver those improvements in the run rate on the forecast. And in addition to that 6.4 million, there's a couple of other million around agency reduction as well. So it's about the organisation actually. The 3.5 million represents the potential we have to slow the significant investment we'll be making in planned care this year. And we've done some analysis. I know that the board would want to understand this properly, what that could look like. So just to be clear, we're spending about £2 million a month in planned care recovery. We said we'd spend 22.9 million. We were only given 15.2. So we're spending and spend what we had. In terms of choices, we can actually halt in-source and outsource activity in the last 3 months of the year, because that is a spend area where there is a switch where we can actually make a physical decision to stop. We would not propose stopping anything else. All the work on pathology, diagnostics, and outpatients will continue. This is about surgical procedures. And that £3.5 million represents 1,020 procedures. And of those procedures, 209 would represent patients waiting over 3 years for surgery based on the current assessment. And just to give it a distribution of that, 11 of those would be in ENT, 33 in general surgery, 23 in gynecology, 7 in spinal, and 135 in orthopedics, where we know we've had substantial pressures over the years. And then that cohort of patients represents 860,000 of that 3.5 million. Our assessment at the moment is the rest of the patients are probably waiting between 18 months and 36 months. And when we're refining that, so in terms of that particular choice, an incredibly challenging choice for us given the length of work that we have. And there's potential, given that we have 24 million pounds of solutions actually on this list at the moment, to consider whether the ones over 3 years would feature in our decision making today, and I'm thinking or not. And I'll let that float, because I think we probably haven't seen it described in those stark terms previously. The other options on that 24 million list around utilising funding more creatively, accountancy gains, slipping investments already in the plan. A substantial amount of that is available to us now. So the 24 million isn't all at risk. I've probably got between 7 and 8 of that 24 million available to deploy against the plan. But clearly the rest is a function of the grip and traction we would have by issuing those control totals and some of the choices around planned care. And just finally on the grip and control totals, whilst that is a big number, I have confidence already that in mental health, in community therapy services group, and of course the corporate directorates, which are all sharing this burden, we've probably got between 3 or 4 million of that identified as well. But as we've already discussed, we need to make some really balanced and informed decisions about where Morriston can go. And in that vein, we still have Morriston at the highest level of escalation in terms of financial support. There's been a change in focus recently with a change in leadership, and what we've seen is the development of an 18-point plan with Morriston, which I saw 2 weeks ago. Tomorrow I'm going to see that plan with numbers against it. I don't have numbers today. And obviously the board will be very interested in the scale of deliverability of that, because that'll be a key cornerstone in terms of the confidence we have in the 24 million landing, or a version of the 24 depending on the board decides today. And the last thing I wanted to say, because there's a lot in there, but I just wanted to get that articulated, is on the cash point, with the extra £60.8 million coming in now, and our ambition to achieve the control total, we've written a letter to Welsh Government asking for £17 million worth of strategic cash, which is what organisations in deficit do, to allow us to settle all the bills up to the end of March. And I know particularly the Vice Chair had a very clear line of sight on this, which was we would have run out of money on my birthday, the 7th of March. The application of the additional money and achieving the control total plan, the strategic cash, will mean we could balance the cash books in here as well. And that requirement was we had to notify that on the 23rd of November, so I'm bringing that to the board for ratification. I know you like brief introductions, Chair, but I wanted to get this sort of sense of the shape and the change in the plan for discussion.
I think that's very helpful. Thank you, Darren. Thoughts, and I'll come to you, Nuria, but I think this is the point at which, for the purposes of the discussions you're going to have, we need some board guidance in terms of some of those decisions to get to the control total. But I would just like to say, I think it's quite an achievement to have got, albeit a difficult, but a line of sight to be able to get to the control total. So I'm going to open up to board questions. Nuria.
I think it's a really difficult position, so thank you for where we are. It's incredibly difficult, and we're now starting to understand some of the implications that this is going to have in terms of our population, which are very stark. In terms of planned care, I think that the question, and I've asked this question before, was about, are we able to do this in a way that supports inflation? And in terms of the extent to which planned care reduction is the contingency option, if other savings don't materialise as planned for the rest of the year, I think it's understanding more what that looks like for me, which is hugely important. I just wanted to make those 2 points.
Did you get that, Darren? Because I couldn't quite hear. This was a bit. Do you mind just repeating for the record? It was other noise.
Clinical prioritisation and whether we're able to do that robustly given where we are at in terms of planned care. And then the other question is around the extent to which planned care reduction is the contingency option if other savings to materialise throughout the plan for the rest of the year.
Yes. So yeah, clinical prioritisation, and if we are more successful, how quickly can we turn back the decision to, basically turn back the tap on planned care?
So I'm happy to pick up the contingency point. I might need to be more clinical or to explore the clinical prioritisation element. So I'd love to have prepared this list without the £3.5 million in it, perfectly frank. That there is risk in the £9.8 million worth of sharing the savings targets out. And hence why we've gone for a number over and above. I think the other thing, before I directly answer the question, is there are other risks and opportunities around the corner as well, which aren't quantified here because it's a very live system. So the impact of the junior doctors, any industrial action junior doctor would be significant in terms of access and potentially financially as well. I think there are always non-binary issues in here, which is, could we assess the next month's financial position and then just hold 1 month of the recovery money back just to see how we go, because if everything else lands, we don't want to turn it back on. Fortunately, the majority of this work is done through contracts, through insourcing and outsourcing, so it is quite flexible in terms of deployment. What we wouldn't want to do is do anything with in-house services because we need to maximise the money we're already committing to those. So in the spirit of landing the others, I think that there is a step-by-step process, which isn't a blanket decision, but let's agree maybe not to do it for January. It's difficult to operate in January anyway, with insourcing and outsourcing. And then at each stage of confidence and delivery of the plan, we could then decide perhaps to reenact some of this for February and March and do that in a very live setting, perhaps between boards, because we need to make a decision about the dynamic.
Yeah, I think that's helpful. Can we pick up on the clinical prioritisation, which I think is an important point? So we're talking here about the greater than 3-year waits and the impact on that. But equally, how do we balance that against the clinical prioritisation, which is an invidious situation to be in? Who's best placed to talk about that?
So I missed the context of the question, so I'll try and pick up and I can come back in if it's the wrong one. I mean, where we are with clinical prioritisation at the moment is the clinical priority is always taking the priority of what we're doing. So some of the reason why we've got the long backlogs that we have is that those clinical urgency levels have changed since COVID coming through, and we are prioritising those patients over and above the more routine long waits that we've got. What we are doing as part of trying to manage those long waits in a better way, make sure we're looking at the patient as well, is
reviewing them all in clinic, so in the clinical environment, and probably a significant proportion of those patients are then opted not for surgery. Now, either because their conditions had improved or we're offering giving them a different offer. And for example, we're starting that now with spinal. So for some of our longest waited in spinal, where we've got a huge clinical prioritisation problem because the urgent and emergency spines come through and take most of our capacity. So we're starting that clinical process for the spinal patients this weekend, and that's where our long waits are. So I assume we're going to get probably a 50% attrition rate by reviewing those patients in an outpatient environment. They then won't progress on for surgery. So it is a fine balance in terms of how we manage the clinical urgency and the really important patient and those long waiters whose condition will have changed, either improved or deteriorated. So that review is a really important step in that process. The other bit I would feed into the turn it on, turn it off conversation. I think Darren's absolutely correct. This financial year, if we step it back and then we're able to put it back in February, March, that should be okay. The risk on that is when we're looking at contracts for next year, other health boards will also be looking for contracts for next year. And the timing of that is really imperative to make sure we can get what we need to do our work as well. But I suppose that's the tiny risk in some of that.
Yeah.
Others might snap it up before we do.
And also, there's, given what you've talked about in terms of the pressures on next year, there is a different decision-making process around next year, isn't there, potentially? Yeah. Because we're balancing a new set of risks. Yeah.
Did that cover off the clinical prioritisation question?
Yes, I did. No, thank you. So I've got Jean and then Rena.
I have mentioned this before, Darren, which is the challenge of the season that we're in and we are going through. So despite the choices that we have to make in terms of meeting this for year end, one of my concerns is, because we don't really have sight of it, is what kind of planning has gone into the finance to meet the challenges that the likes of Morriston, etc., are going through now. So I guess my question is, do we have comfort that the contingency planning to meet these extra surges are sufficient, or is that likely to impact some of the things that you've already talked about?
So if I may check.
Yes.
So the forecast then at month 6 were line by line expenditure forecast and major service groups. So they will have factored into that, not a linear divided by 6 multiplied by 12. They will look at that spend profiles through all of those months. It's fair to say when that was done, we probably didn't have the granularity of the winter plan that we've got now. Within the spirit of this, the reason why I've gone for 24, I'd like to go for more actually, rather than just a simple 18 to get down to the control total is. There inevitably will be costs that we'll incur through the winter that we'll have to absorb into this. I anticipate we can probably accommodate between $500,000 to $1 million in the overall plan, but we need to make sure that the others land as well. The money won't stop the activity, it's just that we use the money then to offset any risk of winter surge that would be required. So there is an element in there of planning, but it's not as refined and up to date as it would be today, given we know the detail of the winter plans.
Yeah. Please keep remembering to speak up. That the room is very long, the acoustics aren't great. Rena.
I just, obviously, Darren, I know you're obviously doing a lot of work at the moment on the area of allocating targets to service areas. Do you feel that we are getting any traction, particularly in terms of run rate? Because my view is clearly the run rate is essential to get down, given what we're facing next year. So if we can do that for the last quarter of the year, then obviously to a degree that possibly could have less impact then on the recovery activity if we can get any further with that. So I just wondered whether you could give us any kind of feeling of what kind of traction we've got on that within particularly the big areas, which are going to be Morriston, Neath Talbot and Singleton.
So I can simplify it down to help with that. So the majority of the run rate pressures at Morriston is just, it's currently assessed as 41 million, but obviously it'll be around that number without any mitigation. There's 12 million pounds in Neath Talbot, Singleton, of which 6 is prescribing. So there's 6 in running the unit, if you like, as a standard unit, as it would be for Morriston, but prescribing is a special 6. And then there are bits and pieces around it that come to the numbers we've discussed. I think prescribing's really challenging. It's a national phenomenon, 11.4% increase in spend this year. I use the word spend advisedly because some of that's about mix of drugs, some less about the price of drugs, some less about drug practice, so it's a multifactorial. From a Morriston's perspective, that pressure of 40 went didn't go away overnight. So what we're doing with the team is working on a challenge of getting 4 million of that out in the next 4 months. And that will set then a multiplier of 12 into the run rate next year. It's fair to say I haven't got the numbers in front of me. What I have got is a list of things that we're looking at around the balance of critical care beds, drug wastage, the reconfiguration of cardiac surgery, giving the move away from open chest surgery to much more innovative practice, constantly looking at theatre consumables, looking at the way in which AD works. So what pleases me with those is they're all service-focused solutions, which would be using the money we've got better, so you get the quality, the safety, and the money bits out, rather than using blunt financial tools, which can often have unintended consequences. The reality is that I think we'll get good traction on that 4 million. At this stage, I can't see 4 million coming out, which is why we've asked others to support with that, and why we're trying to stretch the 24 million above to 17 million to do so. So there's that as some local pressures. At the national level, I've mentioned the Value and Sustainability Board. I'm not going to brief on detail in that today, but 5 main themes of work there coming through Judith Paget's office, which will set a national tone and framework for us to do things perhaps a bit more creatively. So we are playing up into the medicines arm of that. We're playing into the procurement arm, continuing healthcare arm. They're the ones where there's most traction at the moment, and we're seeing some of those benefits play into the financial position now. There's a workforce arm and a clinical variation arm, and it's fair to say those are probably at a more formulated stage at the moment, but we expect to see something more granular. I think we've got to embrace the national umbrella, because that may give us permission to act where we haven't had before. We've got to very much bear down on and support our service groups to get where they need to the range, which will set us up well for next year as well as help us with service.
Thank you, Darren. Pat?
Yeah, just quickly, what's happening to see is is the evidence-based approach to some of the savings on service groups that's coming through. Looking at benchmarking, it's targeting areas where you can see, you know, differences between our spend maybe to others. So that the evidence-based approach is good. And I think the role that Swansea Bay is playing, your staff are playing in the national reviews that are ongoing, and the kind of, you know, leading role you're playing in those. So I think both of those play well for next year. It doesn't diminish the scale of what we face nationally, but I think it's a good approach.
Yeah, thank you, Patrick. Just doing the right thing this year into next year is absolutely where we want to be. Yes, there are some very, very difficult choices in here, but beneath that are those discussions around service reconfiguration, sharing the learning. Our team presented, as you know, to the Finance Delivery Unit, and that was welcome as an approach across Wales. So we're doing the right things. The scale of the numbers is so substantial, and the potential pressures next year adding to that means we have to look at it as a service provision perspective and service change models, as well as just doing the usual pay-per-click management and consumable management, which is important as well.
Yeah, I think that's a really very, very important point. Okay, so I'm going to ask board members, are they supportive of the actions that Darren has set out to achieve the control total of 17 million? And I think that, you know, we are saying in this, therefore, that as a board at present, we believe we are going to be able to achieve that control total. Am I right? Yes, and we will need to put that in an accountability officer letter, probably after we've received this month's figures. Is that right, Darren?
The agreed formal process with Welsh Government is we routinely submit a monitoring return letter every month that goes to the Performance Finance Committee.
Yeah.
It's that letter, which is signed by Richard and myself every month, which will set the control total and our mission to deliver that.
Yeah.
So it's not a special letter, it's just in that letter we need to be very clear.
Yeah, and I think that's very much where the board want to be. I think there is support for your actions. There's clearly concern about the achievability of the run rate, and I know Performance and Finance Committee will be all over that, and understandable concern about the planned care, but it's good to see the granularity of the figures, and the fact that we are going to, you know, if we can, we will turn back on again later on, but we need to have that ability, given the risks you've pointed out in the rest of the plan. And I think we're also being asked to approve retrospectively the strategic cash letter that Darren mentioned. Happy with that? Yeah. Thank you, Darren, and well done. There's been a significant amount of work, I know, gone into this over the last month or so.
No, that's.
Okay, so we now move on to item 2.6, which is the Q2 progress report for the annual.
Yes. So I'll just run through this quickly, because it was discussed in quite a bit of detail, at Performance and Finance on Tuesday. So just to go through this, it provides a high-level summary of the position at the end of Q2, so July to September, in respect of the annual plan priorities. And it shows, and I'm hoping that we're now giving it in a bit clearer kind of fashion so that you can see what the GMO is, what the failure on the red actions, so the only those actions that are off track, and then what the mitigation is to resolve those if there is any, because some require funding. So that's essentially the way that we're presenting it now. And then it gives the performance against the annual plan on the outcome measures. So those would be things like cancer targets, etc. And then the minimum data set, which we have to submit every quarter, has been updated, and that forms part of our normal arrangements with NHS planning processes. So I won't go into much more detail on that, but we went through it in some detail on Tuesday.
Thank you. Any questions from Larissa? Pat?
Yeah, the performance finance, it is a much clearer report now. It flows better and is much clearer. On a point of detail, on the outcomes, the NDD, which is neurodevelopmental, is green.
Yeah.
And yet it's so far off the ministerial target. I was just wondering why the forecast was so low.
Yeah, that's a good question. I don't know. I'll come back to you.
But we're asked to note those, as board, we're also being asked to endorse the updated minimum data set, which was submitted to our government following approval by management board on the 15th of November. I'm assuming we are happy to do. Excellent. Thank you very much. So we now move to the item 2.7, which is the Q2 ministerial priorities performance report, which is Darren, and I think we've got the full health board performance report that's attached as an appendix to this, but we're going to focus on the ministerial priorities on this board meeting.
Yeah, thank you, Chair. I was going to mention that, so thank you for reminding me that is there in full detail. I will be with the Performance Finance Commission this week. This is a relatively new report, but one so far this year. This is the second in that, reflecting September performance. What I thought I do recognise, and the colleagues will have read the report, is just perhaps bring up to date some of the numbers based on where we are at the moment. So I take the board to page 4 of the report. On there, you'll see emergency department 4-hour performance, 77% at the end of September, which is on an improving trajectory in line with plan. That was 76.6 in October, and prior to coming up today, that was hovering between 75 and 76 quickly. That's a number which gets validated, so I'd anticipate future numbers being similar in that respect. From a 12-hour waits perspective, 1,180 in September, nearly exactly the same number, 1,207 in October, and 900 to date. But I know we've had some pressure recently, so I'd anticipate November being similar in those terms as well. Over the page, ambulance access, around 4 hours, and lost hours. Whilst we've had a zero tolerance approach to 10-hour waits, and we're on an improving trajectory through those, we are at high level escalation in the board at the moment, and that'll play into the end of November figure. So I wouldn't like to predict those at this stage, safe to say that there's a huge amount of work going on with our staff and our teams to address those significant pressures at the moment, and which we should remember that we're delivering in very challenging circumstances at the moment. On page 6, you can see the cancer performance. This is always reported a month in arrears anyway, so I don't have the October number yet. My anticipation is it will be similar to previous months. And in terms of the backlog is down to 291 now. That's the lowest it's been in 12 months, possibly longer than that in terms of this report. In terms of the tumour sites, currently the main areas are not dissimilar to as reported here. Gynecology 63, urology remains at 53. Lower GIs improved by 10 to 37, skills improved as well, so they're part of the improving journey. We talked a lot about planned care, just to get the numbers on page 7, 4,600 patients waiting over 2 years at the end of September. That was 600 better. That's the Chief Executive providing this update. and a remarkable achievement in terms of the reduction of 52-week outpatient waits. We're at 0 with the best in Wales, and we continue to press on that as an important indicator. Endoscopy improved as well, and whilst that remains a high number of patients waiting over 50 weeks, that's reduced to 3,007, so good improvement in the month of October. I haven't got the number figures for that. And just in terms of the other ministerial priority areas, child and adolescent mental health features on page 9. Just to be clear on these reports, on these graphs, the top graph, it's better to be above the blue line, so that's positive improvement there in terms of access for 28 days assessment. And on the bottom one, it's better to be below the blue line, because there are fewer people waiting for their care. So both of those are positive reports in that respect. Over the page, the second part of CAMHS in terms of interventions undertaken, again, well above the line, a substantial change in reports, Defence Committee reports. And on the bottom chart there, we're at trajectory, and that downward line is actually an encouraging line because there are fewer people now waiting for their mental health intervention. We just touched on neurodevelopmental. There's a number of paragraphs on that page which describe the work ongoing there, some recruitment going on to support of speech and language therapy coming into the team in the early part of next calendar year. And we've had an NHS executive delivery review of services, and feedback has been positive, albeit recognising that the access we're providing at the moment is below where we'd want it to be. We're doing the right things. We need to see that in a manifesto. Because this is a rounded report that picked up the governance issues and risks over the page, we've debated those. I won't go into them. And from a funding perspective, the funding is being deployed as planned, apart from now the subtle change to the spend rate on planned care recovery. We're still going to spend more than we were given. We're probably going to spend a little less in the context of the financial discussion we just had. Financial plan set up on page 13 and the papers are to note.
Thank you. Thank you very much, Darren. Questions on the ministerial priorities? Keith.
Can I ask a question about the CAMHS service? So on the graphs, it's looking quite positive. The trajectory is good. In the narrative, you describe the number of patients waiting for neurodevelopmental services, so attention deficits and autism spectrum disorders. We've got 1,000 patients waiting there, with 511 waiting over 52 weeks. Are they not in the graph? I can't reconcile those two. Can you give me some assurance about that, please?
You're in there, Chair, for that.
Yeah,
They're totally separate services. Okay, so CAMHS will be a cohort of patients referred in specially for CAMHS, NDD, not CAMHS. Different services.
What we're saying is we're making, because we're making progress on CAMHS then.
Yeah.
I know it's been very, very challenging.
Yeah.
We are making progress on CAMHS, but there is still a significant issue.
Different
for
staffing issues,
different
challenges.
Yeah, it's, I mean, it's your point. I think we need to split it on the risk register as well, because one is making progress, quite a lot of progress actually, and doing really well. I'm not so confident on NDD.
I mean, NDD at the moment, you see, it's where we anticipated it would be at this point with the trajectory. Next month, we will see whether we've made the progress that we anticipated. And I think probably, given the delays that we have in the recruitment, we probably won't. So we'll probably be behind the trajectory when we look at it next month.
Okay, so if there was a flurry of hands there, I'm going to come back to Keith first, because does that answer your question? Or are you, no?
Well, I mean, it's a really helpful answer. It answers the specific detail of my question. I guess if you're a young person waiting for a service, then it doesn't answer the question.
No, it's not. No. So
I think that's why it's important to separate them out, Chair, so you can see the difference. Yes, CAMHS, very specific service. We're making good progress in there. A lot of the lack of progress was around process issues and how we manage waiting lists. It was easier to resolve. There were staffing issues, but actually the process issues that we inherited from CTM. They were causing us a big chunk of the problems. NDD, very specific. It's a staffing and resource issue.
And is the NDD children only, or is that all ages? It is still children, yeah. So I think what you're saying is it's good that we're making some progress, but we need to continue to see that progress into NDD.
Yes, exactly so.
Yeah, no, I think that's right. So Darren and then Nuria.
I think perhaps what might help with for future reporting, Keith, is obviously on the CAMHS ones, we present a percentage measure of access, and then a numerical assessment of numbers waiting.
Yeah.
For CAMHS, for NDD, we've only got the access one.
Yeah.
So if I present a graph which says there's 1,100 now, there's hopefully 1050, then 1,900. It gives some assurance on the volume as well as the length of weight and how those two relate.
Yeah.
Thank you, that would be helpful.
I think that would be very helpful. And I do think it's an area that we have put a lot of effort into, but we need to get this right for the kids in our area, because it's been going on for a while. Rena.
Just quickly, NDD and speech and language therapy are both on our performance and finance agenda as we have like focused areas.
Good.
So we're getting quarterly updated on. But I think the major issue in NDD has been staffing, but also is continuity of funding from Welsh Government, because they've been making extra funding available. But it's been in short sort of periods, not recurrent. And then how do we look to recruit permanent staff without continuity of funding?
Yeah, Marissa?
So the Welsh Government announced 10 or 12 million pounds in July last year for the development of NDD services, and it comes through the RPB route. So RPB have a specific route now on NDD, so that the funding routes come through there. The difficulty is coming down in quite small amounts. So this year, I think it was about 500,000. So of that 12 million. So, and that's got to be split between sort of preventative and then doing the assessment. There is a group now on NDD at RPB, and I think there is a big piece of work to do on that pathway, because the emphasis is on the assessment. But actually, what we need to be doing is avoiding people getting into that assessment process in the first place. So it's a two-pronged approach. One is bringing down the waiting lists and treating and assessing the kids. But actually, there's another bit which is helping kids not get onto that assessment process and working up with education to make sure that they've got adequate adjustments in their schools. So and that NDD service splits broadly between ADHD, and there's medication associated with that, and therefore that's then an ongoing treatment. But a lot of it is in autism, and that is about adjustments in schools and in their general lives, and that is a slightly different way of looking at this as an issue, because there's a child in it, not a waiting list. So I'm hoping that the work that the RPB do start to help this, so that we stop the demand coming into the system.
Great, excellent, thank you. That's a really good explanation. Okay, Yuria?
I didn't have my hand up. I can say something. I didn't have my hand up. I can finish up on a positive note. I think the reduction rate of year or more for a first outpatient appointment is really welcomed, and I think we haven't had that discussion. I think it's worth balancing some of the discussions that we're having. So I would just say that, and I think Darren knows my view on this, which is it's about longevity in terms of what we're looking at. So we're hearing a lot of noise in the system. So that conclusion of where we're at, I think, is more important when we compare, because we know we're going to have months where we're not going to compare very well, and we know that other months will compare better. So it's that longevity, and I think we need to get that understanding as a board.
Yeah, I think that's right.
And the point about the discussion that we've just had, linked to the graphs and the risk register, goes back to the point that Pat made, which she made in August too, which is a really important point about we need to split to understand the risks that we're actually
and very different, and there's different risks.
So I didn't have my hand up.
Just on planned care, I know, you know that there's a lot of, we need to get rid of the very, very long waiters. I know that the board's been conscious of this for a while. That I get a weekly list of where we are on that, and it is pleasingly going down. But this is people that have been waiting over 5 years, which is understandable but unacceptable, totally unacceptable. And I think it will be good when we have that no longer on our horizons. Okay, I think that's good. We will move on now to the winter plan.
Thank you, Chair. I'll keep this brief. Firstly, apologies that we haven't got the winter plan itself on the agenda, and the reason for that is when I received it in preparation for the board, it wasn't ready. So there wasn't enough detail in there. It was a very narrative update. They didn't give us the detail that we would want at board. So this is just a quick update on where we are at the moment and plans for signing off the winter plan. So process is, it's a regional partnership board formal winter plan. So that's done in conjunction with us and local authority colleagues. That's getting signed off by the RPB hopefully on the 12th of December. So it'll be ready to go there. Alongside that, that's supplemented by an operational winter plan that we hope to sign off by the end of this week. All of the service groups have had to review exactly where they are with what additionality they're going to put into the system over the winter period. What we anticipate it will give us, any resource implications go along with that. I've had all of their summaries through at the moment, and we'll be signing that off and then getting it through Urgent Emergency Care Programme Board next week. Where we're going with it in terms of the detail within that plan, we're focusing on the things that we know are working for us at the moment and how do we make them more sustainable. For example, virtual wards, how do we extend the opening hours of the virtual wards? We piloted the integrated discharge hub back in September. That worked really well for us. We're now implementing that as a sustainable programme of work for us. So what we're doing is focusing on how we can avoid admissions at the front door, and then how we work with local authority colleagues in particular to promote the early discharges. One of the focus for Morriston Hospital in particular is they're badging it a Get You Home for Christmas programme to work across, particularly for our clinically optimised patients. How do we move more of those back either into their own homes or into the care home sector? So that's the detail of where we're going with it. I'm happy to take any questions on that, and hopefully I'll present it back when it's been finalised.
Thank you very much, Deb. And just so that board members are aware, I represent RPB chairs on the Care Action Committee, which is a national committee chaired by the Minister on items that is taking a very close look at the capacity aspects of things, so community nursing capacity, virtual ward, and the assessments, particularly trusted assessors. So those are going to be the areas of focus from a national perspective. Any questions for Deb? Yeah, Steve.
Yeah, I mean, generally good plans, Deb, but I can't help notice that tomorrow is meteorological winter. And wouldn't these plans have been better presented 2 months ago? But by the time everything gets signed on, we're deep into winter already.
I think the difference is, Steve, is what action are we taking and how is that formulated into a formal plan? So that doesn't mean we're not doing the action. So the integrated discharge hub, for example, that was implemented 2 weeks ago. So that is up and running. All of the things that the schemes of work we want to extend and do better over winter are things that we're already doing that are working for us, and how do we make them more sustainable? I think one big focus for us going through winter is how we manage our weekends, and how do we do that going in and how do we do that coming out? Because we know if almost falls off over the weekend, we lose the focus on managing the patients in the same way as we do through Monday to Friday. How do we make sure we're shoring that up so we're not setting ourselves up on a Monday? And that's where we're going to focus going forward now. Particularly, we're looking at the first 2 weeks, the 2 weeks leading up to the festive break and the 2 weeks coming out of it, and how do we manage that period in particular. We're also working closely with WAST. How do we, put in different schemes of work across the patch to avoid conveyancing, and how do we do a look at taking patients to the minor injuries unit, etc., instead of coming to the DGH. But we are taking action. We're not waiting for the plan to do the things we need to do.
I can't assume that.
Fair point. Angela.
Yeah, I think there's two things with the winter plan. I think it's one is, we mentioned it to Welsh Government colleagues as well yesterday around the confidence we have, what we are going to try to do will have that really impact on what we need to do. So there's a lot of learning goes behind that. So what have we seen, what we really need to, where are the gaps, what we need to improve, what has worked well in the past, what hasn't. So the work we're doing, particularly around the weekend, that's something which we're literally seeing in our data, that our discharges go down. Our senior cover at the front door is not as good, and we're seeing the changes in our performance. So all of that, really great confidence that it will actually address patient flow and better quality and better patient experience. And I think the other bit is it's really quite a whole system when we're looking at all of the things which are going to go into the winter plan. It is the front door, but it's also that inward reflection. What are we doing in hospitals? What can we do better? And also what is there at the back door. So all of these aspects will be addressed in some form or the other within the plan, so that we have got not all just looking at one particular area, and particularly, as you mentioned, the work in the community. So what have we got already? What can we enhance, and what can we add on to be able to make sure that patients don't even get to the front door?
No, that's right. And we've got to focus on what we've got control over, which is capacity, whether it's within the hospital or within the community. We have, I mean, there is demand in the sense of the prevention, but actually opening that capacity, making sure we've got it is where we, yeah, great. Nuria.
I was gonna just mention the capacity.
I should have kept my mouth shut.
That's absolutely fine. I think it's that capacity, and in particular in the preventative side of things, working alongside our partners to minimise the risk around care home is the right thing to do, and that's part of the lessons learned from previous winter plans. I think I've been here long enough to see them. I think that one of the things that that struck me is that in terms of memory from last year, there was a huge part of what we were looking at in terms of pressures was COVID coinciding with an early flu wave. So I think it's just some thinking around that because it's not as prominent. And I did read the Chief Executive's report in terms of where we're at with COVID, but that's for me the contrast with this winter plan in comparison to last year's.
I think that's a fair point. Thanks, Nuria.
Thank you. Thank you very much, Nuria. Okay, and I think we're just asked to note that, aren't we? Yes, and we'll receive the formal plan somewhat after the time that the RPB has signed it off, which we'll do in December. Okay, so in theory, we have a lunch break, but we're running slightly ahead of time. So I propose that we do the estate strategy, if you're happy, Darren, because the reason we've got an hour's lunch break, and part of the reason for that is that Steve and Raj are going to, and Jula are going to Neath Port Talbot to celebrate the 21st birthday of our hospital there. And we also have Raj out appointing a service group director. So we're trying to balance board membership. So if you will forgive me, we're going to plough on, do the estate strategy, but I promise we will then do the lunch. Darren, yeah.
Thank you, Chair. So a detailed report available to update. Board members will recall that we approved the estate strategy in May. Seems like only yesterday, but 6 months ago, and there's been a lot going on. The estate strategy is in the resources section. Just to set the tone, 75% of the estates over 30 years old, 66% of it is in relatively poor condition. As a result of the 6-facet survey we undertook, we've crafted I was hesitant to call it a plan, a strategy of what we would like to achieve, blending our clinical service ambition with the condition of the estate into a structure of things we'd like to do over 10 years. But clearly that's largely driven by site availability, planning constraints and funding, and therefore the content and composition of that is likely to change, but things we want to do are in there in the right way, in a logical sense. And what this report does today is just shares with the board some of the things we've been doing over the last 6 months. I'll just highlight those in bullet point form and take questions, Chair, that's okay.
Thank you.
So in terms of disposals and acquisitions, we've acquired the former building owned by the Welsh Ambulance Service Trust at Kevin Coyd. That's in a corner of the site where we're planning to develop the extra wards for the adult and acute mental health service. And that gives us the geography to create the co-location of services there. And will also allow us to dispose then the rest of the site, which we're working on through the local development plans with the local authority. We've approved the disposal of the old rundown part of Garnwall Hospitals. The back section is already active service on the front, and we're anticipating that capital receipt this year to fit into the plan. And there's a healthy ongoing debate at the moment around the facility we've got called First Parade and how we might deploy that in terms of being a viable building for disposal or utilisation for other services. I won't say too much more on that because it's running very hot and I wouldn't want to prejudge the outcomes of any discussions that are live at the moment. From a Morriston perspective, excited to report that we've developed plans to reinstate the front of the hospital. Those who've walked through recently in the last couple of years will see that the vision has been compromised by our COVID response. And I've got design plans now which are signed off, which will take out the temporary facility, reinstall the open space, but will also provide a discharge lounge, a much needed fit for purpose phlebotomy area and a lung function suite, as well as providing a staff rest facility, which we've committed to deliver through the partnership forum. And that's pretty dotted around the site for a number of occasions over recent years. We've now got a plan for that, which will be exclusively for staff who find it particularly wearing on the ward area to have a proper break. They can come down, it'll be just for them. So that's progressing, and we're discussing with Welsh Government whether we get funding for that from them or whether we use an opportunity to take funding from the current business that owns the leases for the shops there, but of course there's fluid options about that. In terms of the city deal, we signed off the secondary funding agreement, which will allow funds now to flow for the development of the Institute of Life Sciences and the Management Centre, and we'll also cover off some of the road fees that we incurred. And in terms of ward refresh, again, excited to report that through the Estates Funding Advisory Board, we've secured 7.9 million to start to deal with some of the target ward areas. This is probably more about safety than revolution in the ward in terms of cubicles, but it will mean we can get into some of the struggling roof areas, get the nurse call systems done, refresh some of the fire alarms, will increase quality and safety and actually start to mitigate some of the risks we've seen around business continuity. And I'm very grateful to the combined efforts of the service group directors, Elizabeth Habersington and Morriston, for developing a decant plan which should come to fruition in Q4 to allow us to get into those areas to do that work. The small print table on page 7 is the exciting one. That's all the big business cases we're doing, and it just gives us a sense of the really live and breadth of the live discussions and the breadth of the discussions around our laboratories, the reception to the hospital, the expansion of regional pathology, thoracic centres. You can read them, but it just gives you a flavour. Those are big schemes that we're supporting to do nationally alongside the things we're able to do locally. I've touched on the access route on page 8. There's a good article on the solar farm on the website and on the internet. It's encouraging people to do that financially and in terms of decarbonisation. And we've started to work now with mental health and primary care just to understand what the estate's requirements and service models are for those areas, because we can largely build anything. You just got to know what the service model is that goes in it to work. And that's probably a bit of a second-class citizen in terms of the existing estate strategy. Those are the areas that need to flourish and come through, particularly under primary care estate. We're celebrating 21 years of the hospital, and I'm planning for the end of the PFI in Port Talbot. We're 6 years and 9 months out, and all the guidance says you should start now. So we're upping our game on that. We get some expert advice, and I'll be bringing back to the board quite regularly, I think, what we'll need to do in terms of infrastructure and resource to make the exit as smooth as possible, recognising the complexity of that. Next steps, so we'll be considering more asset disposals in terms of some of the land parcels, plus mainly around the Kevin Coyne site, which is a long-standing, already proved method. I've presented this, the detail of the strategy to Welsh Government and asked them to engage with us actively on creative finance. We're not going to get £812 million out of the normal routes. Those discussions are in their infancy, but that's what will unlock some of the other aspects of this plan. And I think we'll probably stop there and take questions.
Thank you very much, Darren. So this really important document, and it picks up on the question we had earlier around the estate and health and safety. So I'd encourage questions to Darren to probe this. So I can see one from Pat. Yeah. I had a detailed one, but I think it's worth pulling out here that the health board's not in a good position in terms of available capital, but in a good position in terms of really understanding the baseline position of the estate, because you've gone through that 6-facet survey. And that should be good in terms of, you know, timely business case development when funding calls do come out. So I mean, that's a positive. I had a quick detailed question. Decant space in Morriston, you're looking at using Towie Ward. What's Towie Ward used for currently?
So it's at multiple guises as Towie Ward. Currently, it is phlebotomy, a discharge lounge, and the back of it is said decant. Actually, it's been used to trial the nurse call system, the implementation of that in there. So the plan that Darren's got actually replaces Towie then in expansion. It's not a great facility. It's fair to say it was built during COVID as our emergency additional capacity required. It's never really been for the purposes of ward. We use it as emergency and discharge. It's not bedded. It's mostly chairs and trolleys and that.
Thank you. Is that, yep. Yeah, it was in my head. Was it one of the ring fence wards or something?
No, but it's the ugly structure as you walk through the front door in Morriston Hospital. It's not pretty at all.
It would be really nice.
It will vastly improve the patient and staff experience there.
Yeah, no, it will. It really will. Darren?
It is something that I know it's pretty to that point. So when we drafted this, Towie was the option. We've now got another option that's Anglesey Ward in Morriston, and is being managed to create a full ward decant space, which will allow us to do the EFAB work, which is the roof and the call and the fire alarms and things. That will then negate the need to have Towie there, which is when I can start to take that down. So we drafted the paper 2 weeks ago and the landscape changes. So we have a lot of options, and I'm really grateful to Sue Moore and Kerry Gimlet who are working together across sites to work through a decant position. So
that's really
the plan would be to take Towie out in its totality and reinstate that place using then other areas for
My only concern was some of that ring fence space that you've importantly put for like orthopedics and like a fever and stuff, hadn't you? So that's.
Yeah,
that's
no,
right.
no, they're safe in this one. Anglesey at the moment is patients that shouldn't be in Anglesey that we should be able to move out. So between the two service group directors, they're working up the best plan to vacate that. I always take it back to that little game we had when we were children where you need that spare space to move things around, which is where the blockage has been in Morriston. So this gives us that little chunk of space to start doing the work we need to do that.
Excellent. I'm Louise, and then I've got Rena and then Nuria.
Thanks. A very quick one, because you're zooming past Darren. Am I right in thinking that you said that some of the estates work will start in Q4, i.e. soon?
Yeah, so certainly the work to decommission Towie and the reinstatement at the front of the hospital is planned for Q4. We haven't got the funding source confirmed. The paper's currently at Bin government for approval. But that's when we'd want to do that, probably around February time when we've just got a bit more resilience on the site. We're not going to start locking things down into the peak of the winter phase. That's
Right, yeah, that's what I was wondering, because as soon as there's building, there's more health and safety risk, because moving people around.
We can contain the majority of the works around the decommissioning of Towie are that left bit of the main entrance when you go in, which is significantly away from most of the other clinical areas. Anyway, MU's across the way, but there's a significant gap between them. So we can do that. And those plans have been signed off. I'm very clear on sign-offs these days. So been signed off by the site. Deb's had oversight as well, and the capital team understand that.
Great, thank you. Rena.
Yeah, I was part of a working group that we particularly looked at the estate strategy and in particular trying to, I suppose, prioritise with what limited funds we have available. And then one of the considerations we talked about was what else can we do for funding? So I thought it might be useful because in a sense, I'm not sure it's entirely gone into here, but clearly there isn't going to be a lot of capital funding available in the next few years. So we need to be thinking through what other courses of action we can take to actually enable us to move a little bit further forward. So that was one thing. So I thought Darren might want to mention that. And the other thought I had, I particularly got, I'm a Swansea person and I've lived here for all my life. Bottom line is Kevin Coyd has been there as long as I've been there, in the sense that it's even longer. It started in, when was it, 18 something?
Before you.
Yeah. The bottom line is, I just feel quite strongly that in this 2023, that we ought to be having better facilities for our adult mental health. And I really feel quite strongly that we need to move that forward as quickly as we can. And I was going to ask Darren, did he have any ideas in terms of timescales of what's happening with Kevin Coyd?
So I agree entirely about the state of Kevin being around the boards that are still left in the old institution and share your concern. In terms of process, the outline case has been endorsed by government. We're preparing the outline business case now. Part of the acquisition of the West building was it was a free of charge acquisition. It was just transferred between us for us to be able to demolish that to develop the site between us. So I'd expect us to have the case done by next summer, and then after that, it'll go through the approval processes. And there's probably a 2-year program of work. So it's not imminent, but we're through some of the key initial gateways on that. You made the questions then about other sources of funding.
Yeah.
I said we've approached Welsh Government and asked them to help us with liberated thinking on that rather than traditional models. I think we get 375 million a year for capital just for health. Our plan's 800 over 10. So you can, and some of that's discretionary as well. So you can see the disparity in it. We've watched with interest the developments in Velindre and the mutual investment model there, which is struggling at the moment in terms of financial viability given the change in interest rates. So we've got to be really careful that it's a good decision 18 months ago is a poor decision today. But those are the sorts of things we're going to have to explore. And also we need to explore, perhaps less so on the acute hospital sites, but in other areas, partnership buildings as well. So we're looking at the moment at a range of options around Kingsway in Swansea and perhaps a mile or two radius around that to consider what optimum mental health services will be, CAM services, community drug and alcohol. And lots of those facilities work well in combined facilities anyway. But what we haven't got yet is a blueprint for those combined service models. So it's going to be a bit of everything. It's going to be the traditional cases, creative finance, and partnership and other aspects. There's no single solution for the resource.
And the truth is that the creative finances are great, but in terms of looking at the figures, they're not coming anywhere close to 812 million, are they?
And that possibly should have mentioned earlier, there's been Special Estate Services have done a review of estates planning across Wales. And that audit, which we've got a specific version of ourselves, has come up with limited assurance. And the limited assurance is primarily focused on the resource availability to meet the demands of the state. And we were commended in that, having done all the work, then have the strategy which others are now trying to replicate. So that said, we wouldn't plan those box. We know exactly where the challenges are. Some of the EFAB money that's coming through is directly targeting the highest risk areas. But it's not that step change in terms of clinical model cubicles, more fit for purpose model facilities. That's a journey we're yet to have and a fight we're prepared to have. But that's not where we are at the moment. We're just maintaining the continuity aspects for now, while still pushing those modernisation agendas.
Yuria.
Darren has just mentioned what I was going to raise, which is around the limited assurance report in relation to estates and the fact that we do have strategies, so we are in a good place, but yet the capital is a blocking spot. And I think that there is something about us and our risk appetite when it comes to finances and where we are at in relation to capital that we might need to think about. And then there is the side, and despite all of this positive work and seeing the strategy, we've had discussions about transport in the past. I think this links into the quality impact assessment of the straight strategy. I think it would be helpful to just get assurance that that is online, that that's on track, and that that's going to happen.
I did miss that. So the work's underway. I had to bring it today. We've got some absence that the project's not got that to its final conclusion. In terms of service location, there isn't a substantial amount of service location change in this strategy. It's about developing the site's development service plan. They'll potentially have further impacts when you get into sort of primary community estate bits, which is a bit we're working on next. So we'll bring that project and bring it. It's missed the thing.
Okay, so pulling that together then, I think there will be, I think the board it would be right for the board to have a further report in due course, probably in 6 months or so around the primary care and mental health estate, and indeed to get the assurance that the quality impact assessment has been undertaken. But I do take your point about the service aspect of the QIA as well. And I think this is a very useful report in terms of highlighting the order of events and the way in which we're prioritising. But I do think we need to be clear that there is a significant requirement, and it's not a requirement based on a nice to have or aspirational vision. It's a requirement that's based really on health and safety quite considerably, certainly in the first instance, isn't it? And that is a significant risk that the board is bearing. Okay, thank you all very much. It is 25 past. Can we come back at 1:30, I think? So we've got an hour of lunch. As I say, that's partly to accommodate other members that have got to do other things today. But see you in an hour's time.